Hello everyone, and thank you for joining me this evening. In the long-term care facility, the Care Plan Committee meets twice a week to discuss the health and well-being of every resident in the facility. The Care Plan Committee consists of a nurse, dietary representative or dietitian, activities representative, and a social services representative. Family members are invited to this meeting where they discuss changes in the resident's health, social activities, dietary changes, behavioral and mental status. The well-being of every patient is addressed at least once each month, more frequently if the health and well-being demands. This Care Plan Committee delivers coordination of care for the resident of the long-term care facility. But what about the geriatric patient who does not reside in a long-term care facility? Many geriatric patients who do not require the constant supervision and care of the facility can easily be lost in a maze of healthcare providers and medication lists. As life expectancy has steadily increased, so has the predominance of chronic conditions in the elderly. Chronic conditions such as diabetes, congestive heart failure, chronic obstructive pulmonary disease, and Parkinson's decreases the quality of life of the patient and increases healthcare costs by requiring extensive medication management, therapies, and eventually palliative and end-of-life care. Chronic medical conditions are those conditions that are long-standing and as they progress will require close monitoring and treatment to ease symptoms. With a shortage of primary care providers and an ever-increasing geriatric population, management of patients with multiple chronic conditions becomes more difficult. It is complicated even more by the involvement of multiple specialists along with communication and interoperability barriers. Coordination of care and management of chronic conditions have become the focus of many discussions and studies. Improved care coordination has proven to reduce healthcare costs by eliminating duplication of tests and labs, improving communication between providers, and ensuring follow-up with the patient to promote understanding and compliance. Lack of care coordination leads to increased healthcare costs. Many times the geriatric patient may not remember the physician's instructions correctly or not at all, and compliance and follow-up can be lost, resulting in increased symptoms and a trip to the emergency room. If the patient changes physicians, the communication link between the previous physician and medical record could be lost to the current physician and medical record. Is the new physician aware of all conditions and a complete medication list? Is the patient continuing to have these symptoms despite the treatment that the physician is not aware of? Is the patient continuing to be a falls risk? Many of these questions and their answers may not be addressed even if the patient is not changing physicians. The YouTube webinar by His Talk, Jumpstart Your Care Coordination Program, 6 Strategies for Delivering Efficient, Effective Care, addresses care coordination programs in an individual healthcare organization. However, the 6 strategies proposed can be utilized across multiple healthcare networks. The 6 strategies proposed in the video by His Talk are 1. Make meaningful investments in healthcare IT. 2. Stratify patients and proactively reach out to the high-risk and at-risk groups. Recruit the patient to quarterback their own care team. 4. Build a personalized yet consistent patient experience. 5. Manage care transitions. 6. Start with a chronic care management. Meaningful healthcare IT investments means having the right technology and infrastructure in place, expedites the communicating patient data and reduces errors and delays. HealthWise 2017, timestamp 1025. The difficulty of this strategy is the lack of interoperability and lack of standardization between EHR systems and disparate healthcare networks. The second strategy involves analysis of patients and identification of cost drivers. Care for patients with comorbid chronic conditions costs up to 7 times as much as the care for those with only one chronic condition. HealthWise 2017, timestamp 1607. Identifying high-risk and rising risk and at-risk patients allows concentration of healthcare resource applications. Recruiting the patient as a quarterback for the care team will be the most difficult strategy when dealing with the elderly due to anxiety, dementia, medical illiteracy, among other issues. Many times this quarterback role would be fulfilled by a close family member as primary caregiver. Sometimes the patient simply allows the primary care physician to serve as that quarterback. No matter who acts as quarterback, communication plays a vital role in this strategy. Communication and patient education needs to be understandable by the patient or patient caregiver. The manner of delivery must be easy for the care team, but must consider the patient's beliefs and values. The fourth strategy would be to build a personalized yet consistent patient experience. HealthWise 2017, timestamp 2338. Consistency may be the most difficult task to achieve when the patient's total healthcare experience spans across multiple healthcare networks. The patient may see the primary care physician in one network, but may need to see a specialist in another city in a different network. The two healthcare networks may not have interoperable EHR systems, and communications may be fragmented. However, as EHR interoperability becomes a standard in healthcare delivery systems, consistency and personalization can be achieved. Management of care transitions is very important. Who follows up with the patient after discharge from the hospitals? Ideally, the chronic condition specialist or at least the primary care physician would follow up. However, many times the patient leaves the hospital not understanding or remembering instructions regarding medications, labs, or red flag symptoms, and not realizing the need to contact the physician. According to the webinar, nearly 1 out of 5 Medicare patients discharged from a hospital or readmitted within 30 days. HealthWise 2017, timestamp 3104. In addressing this issue, Medicare is approving and paying for transition care management codes. The last strategy is to implement a chronic care management program. As mentioned earlier, chronic conditions, especially multiple comorbid chronic conditions, decreases patients' functions and quality of life and increases healthcare costs. So development of a chronic care management program is very important and follows the strategies for creating a coordination of care program. Like a coordination of care program, a chronic care management program needs an effective EHR system, patient classification, patient involvement, and a thorough care plan and effective communication. According to the webinar, implementation of a care coordination program has resulted in decreased hospital readmissions, decrease in total cost of care, decrease in emergency room visits, reduced affordable ED visits cost by Medicare, and reduced ED utilization by 60% by Medicare patients. HealthWise 2017, timestamp 4005. GRACE, Geriatric Resources for Assessment and Care of Elders, is an intervention model intended to improve the care for low-income geriatric patients through care coordination. GRACE utilizes 5 of the 6 strategies suggested by the HisTalk webinar. Use of an effective EHR and web-based management system, identify the patients to be targeted low-income geriatric patients, create an individualized care plan, and use of technology to assist in monitoring symptoms and management of chronic conditions. The model uses an APN, Advanced Practice Nurse, or nurse practitioner and a social worker working in partnership with the patient's primary care provider, as well as any chronic condition specialist. A cost analysis of GRACE care management intervention gave positive results for the program. In the high-risk group, increase in chronic and preventive care costs were offset by reduction in acute care costs. Council Callahan 2, Stump and Arling, 2009. This cost offset was further enhanced with the improvement of the quality of life. According to the Kaiser Health News article, geriatric patients benefit from geriatricians, healthcare providers who specialize in geriatrics. It makes sense that the care management team of programs such as GRACE consists of geriatricians. Geriatric specialists, whether internists, family physicians, nurses, or social workers, have the knowledge and experience to manage the multiple comorbid chronic conditions that are usually associated with geriatric patients. They are also adept in recognizing and alleviating anxiety and medical illiteracy that is associated with patient noncompliance and lack of follow-up. However, the geriatrician specialty is not a common specialty now, and with increasing geriatric populations, steps are being taken to try to address this need. Not only does the geriatrician understand the effect of multiple chronic conditions, but they also address common symptoms associated with the older patient, such as frailty, falls risk, and cognitive impairments. Many of these symptoms, also called geriatric syndromes, can easily be overlooked by primary care physicians or simply not reported by the patient because they are simply symptoms of getting old. But why should any healthcare network go through the trouble of implementing a care coordination program, especially when so many patients' healthcare is stretched across many healthcare networks? One of the key goals of a care coordination program is to decrease healthcare costs by decreasing duplication of diagnostic tests and duplication of healthcare visits. The care coordination program should prevent hospital readmissions and improve the overall health of at-risk patients. Since care coordination will likely span across multiple healthcare networks, it is important that partnering and strategic alliances be developed for the sake of the patients. This is partnering with potential competitors. This type of partnering occurs when the primary care provider within one healthcare network must work in alliance with a specialist associated with a different healthcare network. This partnership facilitates communication and patient data sharing that is necessary to coordinate care across the care continuum. It is also important that a partnership be developed between the care coordination team and the patient or patient's caregiver. This is partnering with customers. Communication between the patient and the care coordination team must be built upon trust and mutual support. Attention of chronic conditions, common geriatric symptoms, and extensive medication lists are necessary to improve or maintain the quality of life and function of the geriatric patient. Care coordination programs such as GRACE are cost-effective methods to address these needs. Geriatric specialists should be included in the care coordination programs for their knowledge and skill in managing comorbid chronic conditions such as geriatric syndromes. Care coordination programs goals require partnerships and strategic alliances between various healthcare networks, partnering with potential competitors, and between the care management team and the patient, partnering with customers. Thank you for joining me today. I hope you enjoyed this presentation.